morning to all, and especially many thanks to all the faculties who have came here all the way from Pune, Nagpur, Nanded, and Amravati at a very short call. And thank you to the Akola Orthopedic Society for organizing such a beautiful arthroplasty course. So my topic today is the core concept of conventional total knee replacement. When we say a conventional total knee replacement, it is actually and always a mechanical alignment. So what exactly it means is that let the knee be in varus, let the knee be in valgus. The center of head, the center of knee, and the center of ankle should be under a one single weight-bearing axis, that is the McCullish line. And that is what it is, a mechanical alignment. So that the orientation of the joint line is always parallel to the ground. So that is the mechanical alignment, and the joint line is always a parallel to the ground. It was first proposed by Dr. Insal in 1985, and he developed that concept. So there is another person, Ranawat, we know everyone. He is the actual architect of arthroplasty. He described how the soft tissue releases should be there, described various methods of corrections and resections and everything. So this is all his work around the knees, a person to be admired. So what actually in knee replacement we do? The flexion and extension gap should be equal and it has to be rectangular. That is the main aim to achieve a knee replacement. But actually there is asymmetry of the femoral condyle, and to that asymmetry we have to fix the symmetrical prosthesis. So what exactly we do? These are the long leg x-rays, and it is mandatory if you are planning for a conventional knee replacement, that is the mechanical alignment. So you always have to do a long leg x-rays. Every time you should calculate the difference between the anatomical axis of the femur and the mechanical axis, and that should be given into the zigs. So you calculate this on a long leg x-rays or with a CT scan, it is more and less equal. This is the paper telling it. So I always do a medial parapatellar approach. Any approach doesn't make a difference with me. Sometimes I have to do a PS knee because the PCL is very attenuated. So, and removal of meniscus and other things. So this is the zig which we use for a distal cut. So the rod is inside the femoral canal. The red line is the mechanical axis of the femur, and the zig is in the degree of valgus which we have already calculated over the x-rays. So now the distal cut is perpendicular to the red line, that is the mechanical axis. So this is how we put the zig inside for the femoral entry. We attach the pins usually over the 0, 0, because later if I want to increase the resection, I can make it change. There is also some settings over that zig so that I can take more resection if I require in cases of FFDs. And then I remove the zig and I have to take the distal cut. So now this plane of this femoral distal cut is perpendicular to the mechanical axis of the femur and not the anatomical axis, and that is what we want to achieve. So now I have brought the limb in the femur side in one mechanical line, that is the weight bearing axis. So for the femoral entry, this is a very good paper of where should be the femoral entry. It always has to be 9.9 mm or 1 centimeter above the notch, and slightly 4.5 millimeter over the medial side. If my entry is somewhat different, if I do a medial entry, this will increase the angle between that alignment rod and the mechanical axis of the femur. Means I will be resecting more on the medial side, and it will lead to a varus malalignment of the component. So the end result, you will see the limb in slightly varus. If I do much more on the lateral entry, then the resection will be more on the lateral side and there will be more valgus malalignment. So you have to be very much meticulous when you are doing this femoral entry. Same with the, also in the sagittal plane while doing a femoral entry. So if I do an anterior, I am putting the femur into an extension, and if I am doing a posterior, I put the femur into flexion. Earlier, I used to use a very long rod to get engaged into the diaphysis of the femur, but now I use a very short rod, and I do not engage much more into the diaphysis of the femur now, because femur has a bow, and it will let the component go into extension. You can also use, these are the intramedullary zigs, but you can also use an extrafemoral alignment zig. But it is slightly cumbersome because of the drapes around, and it is really very difficult to do that. But this is the only paper I found from Seoul, Korea. So this is how the extramedullary zig, but it is helpful in cases of extra-articular deformities, where we cannot put the intramedullary rod. Then you can use this help of this extramedullary zig to get that mechanical alignment. So intramedullary zig or the extramedullary zig doesn't make much of the difference. Then on the femur side, the anatomical and the mechanical axis is one and the same. So again, along the mechanical axis, I have to do this resection should be perpendicular to the mechanical axis. So this is how I apply. This is an extramedullary zig for the tibia. The lower part of the zig should be along the mechanical axis of the tibia, directing towards the second toe. With the help of the zig, I just calculate 9 mm from the good lateral side, and I take the dissection, the resection of the tibia along the 90 degrees plane to that of the mechanical axis. So again, with the intramedullary and extramedullary zig of the tibia doesn't make much more difference. Intramedullary zig is mainly used for revision of the tibias. So now I do some medial release. Now I have already taken the cut, the distal femur cut, the distal tibial cut. My extension gap is there. Now I want to balance that extension gap in a rectangular way. Medial and lateral should be equally balanced. And now I do slightly some medial releases, slightly go to the posterior side, remove some osteophytes, and this is my preliminary. Now I am balancing the knee in the extension. This is the alignment rod. I put an alignment rod, recheck what I have planned over the x-rays. Yes, whether I have achieved, is the center of the head, center of the knee, and the center of the ankle is in one line. So now, once I have done gap balancing with the extension, now it's time to balance that knee in the flexion. So the posterior condyles are asymmetrical. If I draw a transepicondylar axis, it is usually 3 degrees with that of the transepicondylar axis. So now I flex the knee, I put the block over the cut surface of the tibia, I mark the posterior condyles, how much I am going to resect, and then decide the external rotation of this distal zig. Then I take a posterior cut, and after doing the cut, I again put a block, see whether I have balanced the gap in the flexion at 90 degrees. Then nothing is left, the surgery is done. All the femur cuts, the chamfer cuts, anterior, posterior, all are done. Then flexion and extension gap rechecked after the cuts. So this is how we check into the flexion, at 90 degrees of flexion, and then at 0 degrees of extension. That is 180 degrees you can also cut, and just check whether all the gaps are equal, and both the MCL and LCL are balanced. Nothing, put the components, lateralize the component, lateralize femur, tibia, and if you are changing patella, medialize it, cementing. And this is the flow chart, which I think you should take out the photo because of the constraint of the time. And this is somewhat I wanted to discuss. If I take a tibia cut, this is the Cori's interface. If I am taking the tibial cut more, the flexion and extension gap both are changing. So see the arrows below. If I am taking only the distal cut, see the arrows, only the extension gap is changing, whereas there is no change in the flexion gap. So this helps you to decide if your flexion is tight, extension is tight, flexion loose, what cut you should take. If I am upsizing or downsizing the femur, it is only the flexion gap that is changing, whereas the extension gap remains the same. If I am taking the tibial slope, it is the flexion and extension both are changing, and mostly it changes more on the flexion side. Thank you.
Thank you, Dr. Samir Deshmukh sir, for your detailed about explanation of the restoration of mechanical alignment. Yeah, we have a question.
Okay, which slide you want? Yes, sir. Any questions? Okay.
For the next lecture, I would like to